So good afternoon, everyone. My name is Prashant Kaul. I'm an interventional cardiologist at the Piedmont Heart Institute in Atlanta, Georgia. And I am momentarily going to be joined by my co-moderator here, Jackie Saw. Perfect timing, Jackie.
Great. Thank you so much. Sorry for being late. Wonderful. Good to join you guys here.
And I'll let the other panelists introduce themselves. Lou, do you want to give a quick introduction?
Hi, Salman Lana, Minneapolis Heart Institute.
Great. So the way that this is going to work is that we have several presentations here for this case competition. It looks like we have 5 minutes per speaker, and that's going to be followed by a panel discussion. After all the presentations are complete, the top 2 cases will progress to the competition finals on Saturday. The runner-up will be asked to compete in the finals in case the top selection is unable to. So without further ado, why don't we get started with the first case, Dr. Omar, the use of a dual lumen microcatheter to facilitate left main CTO access and subsequent IVL.
Good afternoon. Thank you all for joining. This is not my presentation. So it's last name Omar, O-M-A-R.
Page 18.
I think they're pulling it up.
How are we doing with the slides back there? If there's an issue with these slides, we can always go on to the next set of the next talk and come back to this one if that helps you guys at the back. Okay. In the meantime, I think we have a full complement of panelists now too. So, Pooh and Michael, if you want to just introduce yourselves.
That's tomorrow's.
Pooh, go ahead.
I'm an interventional cardiologist in Willis Knighton Heart Institute in Louisiana. I just started 7 days ago, so
we'll go easy on you.
Exactly.
My name is Poonam Velgapudian. I'm an interventional and structural cardiologist. It feels nice to have more babies around, so now I can feel a little bit more mid-career.
Awesome, great, thank you. Go ahead. Oh, it looks like we had it there for a moment.
Yeah, they had a different presentation. No, this is a structural one. Maybe there are issues. I can sort it out with them if you guys want to go to the next one. So there are 2 presentations under my name, one's for today and one's for tomorrow.
So you guys at the back, just let us know in the interest of time if we should go to the next one. Or...
There we go.
Oh, we've got it. Perfect.
All right.
Thank you.
Okay.
Go ahead.
So my name is Wally Omar. I was a structural and interventional cardiology fellow. I just graduated. So like Michael, I'll be starting very soon. So this is an interesting case. It's the use of a dual lumen microcatheter to help facilitate some access. You can, can I click here? Thanks. All right, so this is an 86-year-old man with a history of CAD. He had a CABG 10 years ago. A year ago, he presented with accelerating angina, and he presented to an outside facility where coronary angiogram demonstrated an atretic lima. So a drug-eluting stent was placed from the left main to the LAD at that time. 2 months prior to presentation at our institution, he suffered a non-STEMI at a closer hospital, and a diagnostic angio was performed. So as you can see, whatever stent they had placed from the left main to the LAD has now re-stenosed, and also there is a very tight osteal circumflex lesion that looks calcified. Better illustrated here. The lima to LAD was noted to be atretic, so I don't think that they shot it during this angiogram, but the SVG to diag looks patent with some retrograde filling into the LAD. So as discussed, there was severe ISR of the recent left main stent, severely calcified 99% osteal circumflex with a patent SVG to diag. So at that time, his ACS was treated medically. An echo demonstrated newly depressed EF of 35%, but he continued to have angina despite being on optimal medical therapy. So after intense discussion with the patient and his referrings, we decided to proceed with PCI of the distal left main and proximal left circ. We used an Impella for a couple of reasons. We thought this was high-risk anatomy, including the left main. There was a new cardiomyopathy and a question of an atretic lima to think that this might be an unprotected left main LAD stent. Also, the need for atherectomy, given the calcium, made us think there would be some prolonged ischemic time, so we were hoping to get him through that. So for access, we used the Impella sheath in the left femoral. Through that, we put a 7 French crosscut sheath, 45 centimeters, and an EBU 3.5 to engage the left main. We decided that we would have to go retrograde through the SVG graft into the diag, back into the LAD, as we did not have an antegrade channel, so we used a 6 French AL7.5 for that. And this is wiring of that vein graft back into the LAD through the diag. You can see it wasn't actually very difficult to do so. We used a guide extension as well as a Coursera microcatheter, and we were able to wire it with a Xi'an blue. And then once we were able to wire that, we could daughter the lesion with a microcatheter. It was a little bit difficult. A 2.0 balloon actually did not cross after that. So we used smaller balloons to do angioplasty with a 1.0, 1.5, and 2.0. And that actually opened up our channel antegrade, as you can see here from this angiogram. So we proceeded with antegrade wiring of the vessel. So actually we took a Fielder XT and put it into the LAD, took out our workhorse wire from the retrograde, and then given the tight angulation of the retroflex, I want to go back here, circumflex ostium, well, that's not going to play. Okay, so this is actually what we used here was a Suzuki microcatheter to get our reverse wiring. Yeah, if you can click on that. Not going to play, okay. So we reverse wired using a hairpin technique. You can actually see the initiation of that hairpin technique through the second lumen of the Suzuki catheter. And that gave us some nice directionality to actually get into the circumflex and to continue our PCI from there. So from there, we were off to the races. We were able to pre-dilate the circumflex with a 3.0 non-compliant. The LAD was pre-dilated with the 3.5. And then IVUS run on the bottom left here, you can see that the circumflex ostium was very tight. We had circumferential calcium here. And then on the right, you can see that the LAD stent was underexpanded with a significant calcium burden posterior to the stent. So given that, we used shockwave for lithotripsy. We used 40 pulses in the circumflex ostium here and then 40 pulses in the LAD stent. And that actually gave us some pretty good expansion. We were able to do enough to put a 3.0 drug-eluting stent into the circumflex from the left main. We used a 3.0 shockwave balloon for 1-to-1 sizing as well. We decided against stenting the LAD as well to avoid 3 layers of stent in the left main, but this was our final angiogram afterwards, and we were able to post-dilate with 3.5 and 4.0 balloons to open up the vessel pretty well. I don't know if this will play, if you guys can click on it. Yeah, okay. So a couple of learning points here, several take-home points. The foresight and planning in terms of using Impella up front for somebody with a new cardiomyopathy and a left main LAD stent allowed him to get through it with pretty good hemodynamics. We used retrograde wiring, but only to facilitate antegrade wiring afterwards. And then the role of a dual lumen microcatheter in this case, the Suzuki was very nice. It allowed us to intentionally wire the ostium of the circumflex with that tight angulation. Thank you.
Nice presentation. I have a quick question for you. So it appears that when you were injecting from the left main, there was a channel, right? There was antegrade flow. So why didn't you start off first by intervening from the left main antegrade?
Right, yeah, so there was a small channel to get into the LAD. We did not, we thought that if I go back here, we thought that the actual channel going into the circumflex was more of a retrograde channel. And the circumflex was what we were concerned about initially rather than the LAD, but no. Well, I guess these are not going to play. But yeah, so we figured that it would be very tight. It would be very difficult to have our guide engaged into the left main, be able to wire and get through that angulation when we had the open retrograde through the SVG to come.
Other questions from the panel?
Yeah, I thought since you mentioned ACS, I just wanted to point one thing is sometimes you may be, calcium and thrombus may look alike. And so a nice way is to just pass a quick balloon and notice here it's definitely calcium, but that's something that I've been fooled in the past.
Tell us how you, the hairpin technique that you use with the Suzuki dual lumen catheter. So just go over how that was done, and did you pre-shape the wire before you put it on? Like, just go through those steps for those people who may not be familiar with that technique.
Yeah, absolutely. That's a great point. So the Suzuki microcatheter has two lumens. It has a rapid exchange port and an over-the-wire port. So you have your rapid exchange in the vessel that you're not going to wire already. That gives you support. There's about 4 millimeters between the ports of the rapid exchange and the over-the-wire. So what you do is you kind of park the catheter a little distal, the tip is a little distal to the ostium of the vessel you're trying to wire, and then you pre-shape your wire with a pretty angulated bend, enter the vessel that you're not wiring, pull back, and you already have a bit of a hook. And that hook, actually, as you pull back, will put you into the ostium of that vessel. And with the Suzuki, it works pretty nicely, I think, just because of that small distance between the two ports of the over-the-wire and rapid exchange.
A quick question. What was the mechanism of instant restenosis here?
Yeah, so I think that there was severe underexpansion of the stent initially, and I think there, obviously there was a lot of calcium posterior to the stent, so I'm not sure that they actually did atherectomy in the first place. So I think that was probably the mechanism of restenosis.
I haven't used the Suzuki, but was there any issues with prolapse, especially when you had quite a bend, I assume it's 180 bend, and you're trying to hook back? So when you advance further,
Yeah.
is there an issue with
So
prolapse?
that's actually the nice thing with the Suzuki. It doesn't actually, so once you get into the vessel, there isn't a lot of prolapse that pushes you back, and you're able to wire. We usually wire with a workhorse at that point, so obviously there isn't a lot of tension pushing you back with or making you prolapse. But found it, on a couple of occasions to work pretty nicely.
Okay, wonderful. Thank you so much.
Great, thank you.
Thank you.
Just one point. I mean, for the reverse wire technique, the polymer jacketed wires work really well. The Fielder XD or Xeon Black, that's what my experience has been, rather than the workhorse wires.
Okay, all right. Well, thank you very much. We'll move on to our next speaker, Dr. Mohammed Osabi. Did I pronounce that right? Rabi, sorry. So the next title is Undilatable Lesion, a Stepwise Approach. We don't see him in the audience. Mohammed? Okay, well, in the interest of time, we'll go on to the next one. We can always backtrack. Third speaker, are you in the house? Dr. Patel?
Patel, yeah.
Wonderful, excellent. So the title of this case is a tincture of time for the management of heavily thrombotic SVG.
Hey, good afternoon, everybody. So I'm Ankit Patel. Let me see if this advances the slides.
It's the green button, yeah.
It's the green
It's
button
not
there.
going forward.
Are you able to advance the slides there? Okay. Ironically, we're probably back on time since we lost one speaker, so we're probably okay. Just on that last case, just to maybe sort of discuss that with the panel, what, in your sort of experience currently, what are your sort of thoughts about thinking about calcified lesions, atherectomy versus lithotripsy? What is your sort of algorithm about how do you think about cases like that now?
For me, I mean, certainly the intravascular lithotripsy is easier. However, the problem is that it's as bulky as the cutting balloon, so it's not easily deliverable. In those situations, rotational atherectomy, orbital atherectomy are better tools. I've used mostly rotational atherectomy, so I'm more comfortable with that.
So just sorry to interrupt, we've got the slides back up. That was a filler there. But we'll come back to this discussion here in a little bit, but let's keep going with the presentations here.
So my case is a 78-year-old gentleman who presented with chest pain to our hospital, typical angina symptoms, worse with exertion, relieved with rest. He has an extensive past cardiac history with CABG done about 25 years ago, and about 20 years ago he had a PCI of the vein graft to the RCA. Typical comorbidities with chronic kidney disease and prediabetes. Physical exam was just significant for discomfort from his angina. His initial laboratory studies, hemoglobin was 13, troponin was mildly abnormal, and creatinine was elevated at 1.5. So this is his diagnostic cardiac catheterization. We went through a left radial approach, and you can see that the native right has a CTO in the proximal segment with this kind of reflux of flow. And really sort of a challenging CTO anatomically without a good beak. His native left coronary shows the CTO of the mid-LAD, and you can see a high-grade lesion of the ramus, which we'll show in a different view. His Lima to LAD, unfortunately, is atretic after the touchdown and really not really providing any significant blood flow to his anterior wall. His vein graft to his RCA shows a severe proximal lesion that's on the order of 70%, and then the stent in the mid-body is patent from about 20 years ago. And you can see that it supplies a large RPDA and RPL, and then collaterals that kind of feed into the left system. Here's a picture of his vein graft going to his diagonal, and what you can see is a severe, almost subtotal narrowing right at prior to the touchdown onto the diagonal, and then you can see significant thrombus burden. In this view, you can appreciate the TIMI flow down the graft, and then this very organized thrombus occupying that body right where that first sternal wire is. So at this point, this patient was chest pain free when we decided to kind of figure out what would be our optimal strategy here. So we thought through a different number of algorithms. One was, proceeding with PCI, whether CTO intervention or intervening on the vein graft directly with or without a filter wire. Consideration of intracoronary thrombolytics to try to dissolve some of the clot and then proceeding with an intervention. Considering aspiration thrombectomy to try to suck out that clot, because that, as we saw, the Lima to LAD is atretic, and then that diagonal graft is actually back feeding into the LAD. So if you had distal embolization, you're really going to knock out a large chunk of his myocardium, and the RCA is already compromised as well. Do we stop and anticoagulate and try to come back a few days later to see if that dissolves? And then consideration for redo CABG, which I think we just always write to make surgeons feel like they're part of our team on a re-op. So for us, what we decided to do was load him with dual antiplatelet therapy. We started systemic anticoagulation with heparin, and we planned about 48 to 72 hours to bring him back into the cath lab. In that interim window, he did have mild intermittent angina, which we medically managed. He did have ectoby, but it wasn't anything sustained. Hemodynamics stayed stable. His echocardiogram showed a depressed DF of 30%. There were regional wall motion abnormalities, but no significant valvular pathology. His troponin did go up to 17 with the typical end-STEMI pattern. And he was presented at our multidisciplinary team meeting. And at that time, we decided that our thought approach was if the graft to the diagonal, the thrombus had resolved, that we would do a protected PCI, so have an Impella-supported PCI and try to do a complete revascularization. The thought was entertained about doing a CTO intervention, given the fact that these are 25-year-old grafts. The issue was that you had a CTO of the LAD and a CTO of the RCA, and trying to open that up was felt to be much higher risk as the initial intervention. The thought was, let's see if we can intervene on the vein graft and then stage a CTO intervention if needed down the road. So here we went radial because if we were going to have significant thrombus, we were going to continue to anticoagulate them and maybe do further evaluation. But we can see that the thrombus that we had seen in that vein graft body, it's completely dissolved. And you see just a focal severe lesion where the first sternal clip or the second sternal clip is. So we decided to proceed with Impella supported PCI. We went ahead and first fixed the RCA graft by putting in primary stenting. We sized it up angiographically just to minimize catheter manipulation. Normally I do a lot of IVUS guided or image guided PCI. With 25-year-old grafts, they become a little bit hesitant of no reflow phenomenon of trying to manipulate catheter, so we stented it with a 4.0 stent, and it looked well. And you can start seeing really the collaterals going to the left system. And then we went on to the graft to the diagonal, and here we placed 2 stents, one stent covering that severe subtotal 99% stenosis, and the one proximal to it, because as we started wiring it, we saw that there was a 70% lesion there as well. And then to do complete revascularization, we tackled the ramus that I wasn't able to show previously, but you can see a high-grade lesion in the ramus. The circumflex system, given the fact that the right is so dominant, has disease in that OM, but it wasn't felt to be severe, and we fixed the ramus. So on follow-up, the patient was discharged successfully home on guideline-directed medical therapy. On 3-month follow-up, his EF had recovered, and he had no further admissions for angina or CHF. So we're going to follow him and decide whether we need to do anything. We recognize that vein graft interventions have a high failure rate, but for him, he has done really well. We also took into account the fact that he is 78 years old, and we wanted to balance his any risk of contrast-induced nephropathy. So really, for take-home messages, I think this is a really demonstrative case of taking a therapeutic pause and to really figure out what would be our best procedural plan. Yes, the patient's coming in with an acute coronary syndrome, but he's hemodynamically stable, he's pain-free at the time of our diagnostic cut. So we had the ability to kind of figure out a better plan rather than tackling that thrombus up front. A trial of systemic anticoagulation and DAPT can really help reduce and eliminate thrombus burden, and I think that does play a role with reducing your risk of no reflow phenomenon when you do these interventions, and the importance of a multidisciplinary team and using mechanical support to help depress the Fs, multivessel PCI, and when you have renal insufficiency. I just wanted to give a thanks to Dr. Vavia, who's one of our senior attendings.
Nice case and nice results. My question to you is, you didn't choose a 2B3 inhibitor integralin. Why did you select heparin versus, maybe even in addition to that?
Yeah, no, that's a great question. So we loaded him with dual antiplatelet therapy, and we knew we were going to wait 48 hours to 72 hours to bring him back to the lab. So I felt that aspirin and Brilinta, which is what we used, would be sufficient for antiplatelet suppression at that point. But if we were going to do it more acutely, then absolutely, I think integralin or even cangrelor would be a good option there.
You're going to ask the panel who would use at 2B3A, or who would even consider just using intracoronary thrombolytics instead?
I think I would go with the heparin and integralin at the same time, especially with that heavy thrombus burden. And the other option that you said also is considering penumbra then doing that. So you would have less risk of coming back with more thrombus.
And I think from my perspective, it would depend a lot about your view of the case presentation. If you thought it was more ACS, I think you could lean a little bit more towards antiplatelet. And if you thought it was a little subacute, it might be more organized, in which case thrombolytics might be a little better match for your cross-linked thrombus that's well organized and sitting in there. I was interested, did you guys use standard ACS guided dosing for your heparin, or did you try to go a little more aggressive?
We went a little bit
than that?
higher, yeah, because our initial cath was through the radial approach, so we had complete hemostasis, and he really didn't have a bleeding diathesis. So
Poonam, what did you think? What would you?
Yeah, I would have, in the acute situation, used heparin and GP2B3A intracore,
So in
and
combination?
like 2 boluses, and then did a drip if needed for 6 to 12 hours, or 12 to 18 hours.
I would personally use heparin and cangrelor. I mean, most of the data for glycoprotein 2B3 inhibitors is newer P2Y12 inhibitors, and especially there is older data that has shown adverse outcomes with the use of glycoprotein 2B3 inhibitors with graft intervention. So I usually avoid glycoprotein 2B3 inhibitors, especially in these kind of scenarios, especially when cangrelor is available and newer P2Y12 are available.
Yeah, that's a fair point that Michael's just made. I mean, cangrelor is on the market. Most formularies have it, but the cost is, in many cases, prohibitive. So personally, I would probably also use a 2B3 inhibitor with heparin, at least up front. And then I think your point's well taken about, switching to the oral agent. The question I have for you is, what were the patient's hemodynamics, EDP? I was just sort of going to push back a little bit on the use of the hemodynamic support. Do you think you could have got away without doing it?
Yeah, so during his diagnostic cath, his EDP, which I didn't say, was about 35. By the time we did the intervention, his EDP, we had optimized his hemodynamics, but his EDP was still 25. And the fact that we were concerned that these were 25-year-old grafts, if we got no reflow, that we would have pretty poor outcome. And that was the reason why even though we shot the vein graft to the diagonal, we fixed the vein graft to the right first to try to get as much myocardial protection and reduce our overall ischemic burden. But I agree. I think you have to have a thoughtful approach on LV support. I think sometimes we overuse it. And the other issue is his renal function was a little bit abnormal, so that kind of tipped us over as well.
Thank you.
I think your order of operations was very sound in that even on that initial angiogram, you saw a little bit of collateral filling from the right to the left of the distal LAD. So once you're going to get into the tiger country with all that thrombus, I think it's nice to have as much safety from your other vascular beds as possible.
Yeah. I just have one question. I want to know what the panel thinks as well about the vein graft to the right. This right was huge, and this was kind of an ostial stent. So will you only follow him clinically, or would you guys schedule the RCA, CTO, PCI just in 2 months? What do you think?
Go ahead.
I was going to say his graft was, 20 years ago, right? 25 years ago.
Yeah.
And he's done pretty well on the right side. So I would be tempted just to leave the RCA, CTO.
And he had an intervention in the right previously. That
Yeah, in
actually
2005, so
stayed
20
open.
years ago. Yeah, and it stayed open.
Impressively.
Yeah.
The difference is just this is ostial, and
It is.
ostial is like 70% will.
And it's depending on his renal function.
Of course.
That is a big enough vessel that you could potentially, depending on your facility, assess it with a CTA.
Yeah, I think in the setting of, what was going on the left side, it probably, wasn't unreasonable to do the way that he did do it. But ultimately, I mean, most people who kind of do CTOs, for a living, they think that vein grafts are only good for one thing, and that's to go retrograde to open up the native vessel. So it depends who you ask. It depends on, the experience and what kind of lab you have set up. But I think in this particular case, it was quite reasonable, I think.
We have other uses. Great.
Thank you, everybody.
Yes, so let's move on to the next case. We're right on time now for the next case by Dr. Radida. Case Radida, shockwave lithotripsy is the last option to restore flow. All right, people are dropping off. The competition's getting less and less here. Okay, so let's move on to the next one then. Is Dr. Sadana here, Punish Sadana? Dislodged stent, Dr. Sadana? No? Okay, all right. Dr. Selwanos, Peter Selwanos? Awesome, excellent, yes.
Just showing up, you get a prize.
Yeah, so revealed pouch after CTO canalization, how to defeat. Thank you.
Thank you. Good afternoon, everyone. My name is Peter Selwanos. I was working in Aswan Heart Center from Egypt. I have nothing to disclose. My case is 56-year-old male patient known to have hypertension and dyslipidemia. He underwent primary PCI to LAD 2 years before presentation and was scheduled for CTO RCE. At that time, he was complaining of angina, class 2. You can appreciate that he has proximal ambiguous gap, RCA. And firstly, we adopted for our antegrade wire escalation technique. Fielder XTR failed to cross the occluded segment. Then finally, guy 2, supported by Turnpike LB microcatheter, finally did the job. And here is the pre-stenting IVUS. You can appreciate that it was a small vessel, 2.5, 2.75 at mid segment, and the 3 on the proximal segment. That's negatively remodeled. And after some difficulty in delivering the stents, we used a Grand Slam wire and putting the PM in the conal branch for anchoring. And then we deployed the 2 overlapping stents, 2.5, 34 millimeter, and 2.75, 8 millimeter as a met from the distal to proximal RC. And we post-dilated the stents by NEC 3 and then 3.5 proximally. And we ended by final angiographic results. And post PCI IVUS showed well-opposed stents. After 6 months, the patient had some improvement, but still complaining of angina. And we, as a part of the program research follow-up after CTO PCI by 6 months, angiographically and intravascular imaging, we did him coronary angiography for the RCE, and we found filling defect in the distal stented segment. And after zooming on, we found an area of peristent haziness and peristent contrast staining. So we have differential diagnosis, thrombus, neointimal hyperplasia, dissection, and calcification. We did OCT, and the OCT revealed a pouch aneurysm behind the stent struts with late-acquired stent malapposition and some thrombi behind the stent struts. So we post-dilated the area of malapposition by 2.75, then 3.15 NEC balloon. And another OCT run revealed well-opposed stent on the RCA and good final angiographic results. So late-acquired stent malapposition defined as separation of at least one stent strut behind the intimal vessel wall and results from multiple numerous pathophysiological mechanisms. The most common one is positive remodeling, which results from the increase in the total vessel wall with a change in the external elastic membrane out of proportion to the increased area of the black and medial area. The second mechanism is thrombus dissolution with decreased black volume. And the last theoretical one, which has not been confirmed by the intravascular imaging, which is stent chronic recoil. We have multiple risk factors for this phenomena, clinical and procedure related. The highest incidence of late stent malapposition comes from mission study among acute MI who were delivered sirolimus regulating stents. Unstable angina, presence or absence of diabetes, there is controversy on this issue. Some literature goes with poor glycemic control leads to delayed or less efficient drug effect. Some literature goes with pro-inflammatory states of diabetes predisposed to very late stent malapposition, and guided by Steigenberg et al., who was found that this phenomena is common among younger patient age. There are numerous procedure-related parameters: use of drug-eluting stents, use of directional coronary atherectomy, CTO, ACC type C lesions, longer stent length, overlapping stents, vessel size, and finally, lower maximum balloon pressure. Here, the diagram showed the both broad categories of late stent malposition, either persistent or acquired stent malposition. Here are some controversial issues. What are the clinical implications? Till now, the studies couldn't find clinical impact on the MACE, major cardiac adverse cardiac events after stent malposition. Is it important to quantify the malposition? Some people say that the malposed area more than 4 millimeter square is significant and produced high clinical impact. And numerous algorithms taken into consideration also the uncovered with delayed endothelialization as new intimal healing score. And here is the peristent contrast staining classification for this. To optimize or not, back to mechanism. Late acquired malposition associated with delayed covered stent. This explanation argues for stent optimization, but stent malposition is a clinical marker for inflammatory and hypersensitivity reactions. This would make optimization make nonsense. So to optimize or not optimize, a reasonable approach is to optimize guided by intravascular imaging using OCT. A prolonged depth, we put this patient on prolonged depth for another 1 year, but on the expense of high bleeding risk. There is some agreement that to prolong depth, but with expectation of high bleeding risk. There's excerpt from the state-of-the-art Eurointervention 2021, which showed that late acquired stent malposition didn't affect the clinical outcome. So my home message, intravascular OCT is a valuable complementary tool for diagnosis of coronary lesions, especially during a follow-up of complex CTO procedures with higher sensitivity than IVOS for detection of late acquired malposition. Late acquired malposition represents a well-recognized problem in interventional cardiology that became more prominent in the era of drug-eluting stents, with higher reported incidence than perimeter stents. Factors associated with the lesion complexity, such as longer stent length, CTO, C-type lesions, overlapping stents, have been associated with an increased risk of LASM. Existing data regarding the clinical outcomes in patients with LASM are controversial, largely arising from observational retrospective studies. The fact that the rate of LASM remains vastly greater than the incidence of late stent thrombosis strongly supports that notion that stent malposition is not necessarily a sine qua non for stent thrombosis, but merely one of the factors in a complex interplay between patient lesion and stent characteristics. And thank you.
Thank you. Interesting case. Do you mind just going back to your initial angiogram after the stent when the patient came back? I was just curious to look at the imaging again now that we've sort of seen the case, and maybe I'll ask the panel. So do you, does the picture on the left play? Would anyone have just left it be and maybe managed with medical therapy?
You know, one of the questions I had before addressing that is how confident are you to say that it wasn't from underexpansion? You didn't do intercoronary imaging after the PCI was done originally 6 months prior. So is that really, you're confident it's late stent malposition versus just underexpansion to begin with? And I must say, just looking angiographically, it looked pretty minimal. I mean, I'm tempted to leave that. I'd like to hear what others have to say.
I guess I agree. I mean, I applaud you for using intravascular imaging. I think that's great, but your stent was widely patent, and it would be somewhat tough to square that with his clinical presentation of increasing angina, unless you presuppose that he was having some sort of intermittent thrombotic event. effect or event. But I also would have been tempted to leave this be just because I'm not sure it was causing his symptoms.
I wouldn't have found it. I wouldn't have found it. Finding on OCT that is very...
Yeah, I think that's right. I think it speaks to the sort of importance of imaging when the diagnosis is in doubt or you're not sure what's going on. So very, very important to do intracoronary imaging in these cases. Poonam?
Yeah, again, I agree with the others that I probably would have left it alone. I'm not convinced that the symptoms are from this because the stent area was pretty good from the imaging. So I think I would have left it alone, done a long-term DAP, good anti-anginal therapy, and then see how he does.
Salman?
Hard question. Once you see that, it's kind of hard to look back and leave it alone too. So just because I'm a little OCD, I would have imaged it because I want to know. But I think leaving it alone would be reasonable as well.
If I can add, in the old days of the Cypher stent in Texas, and in that era, I would say that, gosh, I've seen some horrendous late-stem malposition, especially in SCAD patients. They resorb to hematoma and you put in a Cypher stent, and I've seen some of the worst cases. That's when late stent thrombosis occurred in those patient population, and so this, relatively speaking, looks pretty benign.
Yeah, and in many of those cases, you would see sort of more pronounced outpouching, a pseudoaneurysm or aneurysmal segment of some description. But interesting case. Yes, comment from the floor.
Yeah, he is quite symptomatic, but he has another lesions in circumflex, and we did it on this same session. But actually, we did OCT as a part of research follow-up after CTO recanalization.
Okay, good. Thank you so much. We'll move on.
Thank you.
We saw a number of new people join the room here, so if you've missed your case presentations earlier, by any chance? No? Oh, too bad. Okay, then. We'll move on to the next case. So this is Dr. Simsek, okay? And you will be speaking on multiple thrombectomy technique and eptifibatide marinade in a challenging to recanalize vein graft thrombotic occlusion.
Thank you. Good afternoon, everybody. My name is Bahadir Simsek. I'm a research fellow at the Center for Coronary Artery Disease at the Minneapolis Heart Institute Foundation with Dr. Berlakis. Thank you very much for the opportunity to present our case entitled Multiple Thrombectomy Techniques and Eptifibatide Marinade in a Challenging to Recanalize SVG Thrombotic Occlusion. I don't have any conflicts of interest. Our patient is a 74-year-old man with a prior history of myocardial infarction 29 years ago, coronary artery bypass grafting with Lima to LAD, SVG the first diagonal, SVG the first obtuse marginal, SVG the circumflex 16 years prior. He also had a PCI with regulating stent to SVG the first obtuse marginal 4 years ago due to NSTEMI. This patient now presents with NSTEMI and is referred for coronary angiography. Here are the diagnostic angiograms. We can see that there is about a 90% stenosis of the circumflex and a proximal to mid-LAD CTO. Not demonstrated here is a known history of RCA CTO. Here are the angiograms of the bypass grafts. Lima to LAD is patent. SVG to first diagonal is 90% stenotic but has a timid reflow. SVG to first obtuse marginal is 100% occluded and is the culprit lesion in this patient. Wiring of this lesion was challenging, requiring several attempts with multiple guide wires. The lesion was finally crossed with the help of a Corsair Pro microcatheter and Gladius Mongo. However, anterate flow remained absent. Therefore, anterate flow was then established with guide extension and ballooning. After the anterate flow was established, we performed multiple passes with penumbra aspiration device over here. However, anterate flow remained absent. And then anterate flow was established over here. As you can see, large amounts of thrombus remained in the lesion. Due to the remaining large amounts of thrombus load, a technique called armored aspiration technique was then performed. In this technique, a 0.035-inch guide wire is inserted, as you can see over here, into the lumen of a 7-French export aspiration catheter, rendering the aspiration catheter stiffer and facilitating its delivery to the target thrombotic segment. After the armored aspiration technique, anterograde flow further improved. As you can see over here, however, large amounts of thrombus still remain in the lesion. Therefore, a decision was made to marinate the lesion with eptifibatide infusion and reevaluate the situation. After about 2 days of eptifibatide, this is the angiographic result, and a decision was then made to perform PCI here. Stents were deployed under IVUS guidance. Distal embolic protection was also used, achieving a nice final result. In summary, thrombosed SVGs with heavy thrombus load might be challenging to recanalize. Multiple aspiration techniques, including penumbra or aspiration through deeply seated guide or guide extension, as well as armored aspiration technique, can facilitate successful recanalization of these challenging lesions. In addition, prolonged infusion of glycoprotein 2B3A inhibitors followed by delayed stenting may also help in the recanalization of these challenging lesions. If you have any questions, I'd be happy to answer them. Thank you very much for the opportunity.
Great case. Again, quite similar to the earlier presentation as well. And I think, there would be merits to actually adding both the 2B3 inhibitor and the heparin as well. And I still am curious about, using intracoronary thrombolysis. And there's a case session this morning, we discussed using TPA for acute STEMI cases, and I think that might also facilitate that. Any comments from the panelists about that use?
I've never used it. It's conceptually, it makes a lot of sense, especially as thrombus is more organized, but I would be interested. I have a separate question, but let me throw it to the panel first before I get back to that.
I've used intracoronary thrombolytics just once ever in a 93-year-old patient with extensive ectatic right coronary artery. Of course, it did give a good result, but at the same time, of course, there's limited data available to do that too. I don't know if nowadays with the use of CAT-RX with the penumbra, do we still need to do that? But I think I'm sure we'll run into some cases where there's so much extensive thrombus that cannot be aspirated with even penumbra. And I think in those situations when you are struggling, using epi with the recent data for no reflow, although it's been in native coronary arteries, penumbra, and if it doesn't work, I think it's a very reasonable strategy for me.
Yeah, I haven't used it at all, maybe once in training, but that's about it. But quick question, how was the patient doing? You almost talked out everything. I was worried the artery would come out too.
Yeah, so we almost have about a year of follow-up, and there's no MACE, no MI, nothing, no symptoms. He's doing well.
That's all. I think, to your point, I think intracoronary thrombolysis compared with systemic one, I don't know if you just can spray 4 milligrams of TPA, let them marinate for 30 minutes, and then bring them back, or how do you do it exactly?
So that I asked that exact same question because I haven't used it since my fellowship, which is a long time ago. And so number one, we don't even really stock TPA, right, in our cath lab. So I asked my pharmacist that, we can get the vial, we can mix it up. And apparently the standard dosage, it can be quite variable. But 1 to 2 milligrams to start, maybe up to 10 or even 20 milligrams intracoronary. And apparently some of the cases that was shown this morning, you give 1 milligram and you wait a minute and literally you see that thrombus and you just re-inject and that thrombus was gone. That was in the right coronary artery, not perhaps in a big vein graft like this where there's maybe even a lot higher thrombus burden. But I'm kind of rejuvenated to think I want to give that a go next time I see this. My natural response typically is to just run 2B3A for 48 hours plus heparin, plus minus heparin. But I think this can give us maybe more accelerated form without the risk of bleeding. And in Canada, we're pretty poor. We don't have cangrelor, unfortunately. And we also don't have penumbra. So these additional marinades that we can use, I think, we'll give that a go.
And anyone would consider using, if the CAT-RX did a really good job, but still there was no flow and heavy thrombus, anyone would use, peripheral penumbra on this vein graft, considering it's big. We had an 035 wire already.
Yeah, I would sort of probably resist that temptation to do that. I've used intracoronary TPA in the past with varying success. It's worked, sometimes it hasn't. But over the years now, my current practice would be to do exactly what you suggested, Jackie, which is to just marinate for 2 to 3 days on an intravenous 2B3 drip, and then bring them back and see, and probably also have a lower threshold for kind of approaching the native circ OM system. I mean, there was a favor, there was reasonably favorable. So that may have been, oh, I'm sorry.
No,
but
perfect. I was going to ask the same thing in that.
Yeah, why don't you ask it? Go ahead.
How did you guys choose the occluded vein graft versus the subtotal circ as your culprit? Because I think it sort of goes against the mantra that we're moving towards these days. I like to see folks working on vein grafts when it makes sense, but...
Yeah, absolutely, that's a great question. In this case, the SVG was to the first obtuse marginal, and obtuse marginal was a CTO. However, due to the presentation, which was end-STEMI, a decision was made to pursue the PCI of the graft, and then if in the longer run, if the symptoms continued, then we would have a conversation with the patient and then maybe go after the CTO over there. Because the graft was to the OM, and it was a CTO, so potentially could have been a high risk, and due to the acute presentation, that was the choice.
And I think sometimes you see this, you think you can go in, suck it out, and you'll have great flow, and then once you stick to the strategy, you continue.
And Manos is a thoughtful guy, but once you start putting a 035 J wire backwards in an aspiration catheter, I would at least want to think about addressing the vessel with some antegrade flow.
Yeah, speaking of flow, though, just could you go back a couple of slides? Show us your last picture again. So what was these were your last pictures. How did the flow look at the end? What was the, just go back one more slide, and then play, yes, is it, can we play, yeah, there you go. Let's just see. So yeah, reasonable flow, and maybe not the best blush, but everything's open and obviously looks much better than previously. And I think this gives you, but also buys you some time to go back and electively maybe think about that, because the likelihood of this staying open long term is probably not the best.
Yeah, sometimes in the organized thrombus, we've used laser too.
Yeah,
and
good
it
point.
softens the thrombus.
Excellent. Thank you. Congratulations for that case. Thank you very much. Okay, I'm almost scared to ask. Do we have Dr. Youssef, Mina Youssef? Yes, excellent. Okay, great. So we're going to hear about a bifurcation nightmare from Dr. Youssef.
Okay, good afternoon. I'm glad to be presenting today. So I'm talking about a 78-year-old male patient. He is a smoker, diabetic, and hypertensive. He has history of TIA. He is presenting with typical chest pain occurring at rest. Examination was within normal. This was his ECG. He had some ST depressions, and his echo was within normal. His cardiac enzymes was elevated, and it was showing a trend of non-ST elevation myocardial infarction. This was his left coronary system. As we see, he has subtotal occlusion in the ostial circumflex and has a significant disease in the LAD. His right coronary artery was normal. At this stage, his syntax was calculated, and it was 21. We were between choosing CABG or complex PCI. We went for the complex PCI, though we didn't have IVUS on shelf. So we started with an XP guiding, 7 French. two BMW wires into the LAD and the circumflex. LED lesion preparation was done using semi-compliant 1.5 by 2.0. After this, the drug-eluting stent 3 by 22 was parked in the LCX. Another 3.5 by 26 was parked in the left main LAD. We started by inflating the LCX stent, as shown in the right video. After this, the circumflex wire and balloon were pulled out, and the stent was deployed left main LAD, and we had a control angio showing good flow, but we took a deep breath, but the job is not done yet. After this, we rewired the circumflex and opened the struts, and we did a final kissing followed by pot for the left main, and this was our final results. The technique we adopted in this presentation was the mini crush technique, and it went well. Thank you.
Great, thanks for that case. I was sort of catching my breath for the nightmare of this case. So, and I was thinking what the nightmare might be in this case, and I would probably submit to you that the nightmare was probably not having an IVUS catheter on your shelf.
Yes.
Is that?
That's the truth, yeah. That I had to do a complex left main bifurcation ad hoc without any preparation to it, and a patient was complaining of a chest pain that was ongoing in the cath lab.
So tell us about where you practice, and so you're in Cairo, is that right?
Yes, Cairo University.
And do you have surgical backup there, or what is the sort of setup that you have?
Yeah. In our cath lab, we don't have IVUS on shelf. We can get it at extra cost for prepared patients. But for the emergency patients, we don't have access to IVUS. For the surgical team, they take cases with enthusiasm. Except for the infarcted patients, they tend to be slow and reluctant if they have infarcted myocardia. That's why, while thinking about my patient having his enzymes elevated and he was having ongoing chest pain, I was thinking that if I delayed him for the surgical team, they will go for multiple days before he goes into surgery. With ongoing chest pain, that's why I adopted a complex PCI for left main without having imaging for left main.
Wonderful. The results look really good. And I have a question just for the panel. Would you have done anything different in terms of your approach? Instead of using a mini crush, what would you do differently?
No, it was done perfectly, but yeah, you guys say there is IVUS in Cairo, okay? So we don't. I'm Egyptian, man.
Yeah, we have IVUS, but we don't have it in acute cases, yes.
Oh, we could do a QCA.
Sorry.
You have a catheter in there, I mean. But I think, yeah, I would have done the same. I usually use DK crush.
I mean, DK crush is my go-to strategy too, unless you really have a difficulty wiring the side branch, and you're worried about that the side branch you may lose it. Then in those situations, if the vessels are pretty much closer diameter, I would use school out, but DK crush is my way to go strategy. One question I have from the panel is, in these kind of situations, you don't have an IVUS. There is STEMI 3 flow in all the arteries, all the patients having chest pain. And I know that we don't have any data, but what does the panel or the audience think about putting in a balloon pump, and since the patient was having chest pain, putting in a balloon pump and taking a thoughtful pause and see what would be the best strategy to go forward?
I think it depends a lot on the hemodynamics. Prashant mentioned it earlier with one of the prior cases. I think it's important to really pay attention to the hemodynamics in this case. If the heart rate's 110 and the EDP is 30, you have some tricks in your bag to improve that and potentially stabilize your patient. If they're unstabilized, I think that's when you think about one of these more rapid left main bifurcation techniques. I agree. I tend towards DK crush, but this result was beautiful, and I think a nice thing to have in the bag when you got to move fast sometimes.
Yeah.
I think that, anytime you're doing left main PCI, you should, the three techniques, I think, in contemporary left main PCI that we talk about are, in addition to DK crush, culotte and tap. And really, actually, we were just discussing this in the previous session, but the specific technique that you use often sort of morphs as the procedure goes on. So after you've wired both branches and you've pre-dilated both branches or prepared or done atherectomy or whatever you need to do, sometimes your initial choice of technique may change. So you may decide initially that you're going to do a DK crush, but then you may need to deploy one of the side branches more quickly. You may have to convert to a culotte or an inverted culotte or something different. So being facile with all of these techniques and being able to sort of adapt to the situation is also very, very important. And I think that, although DK crush has the most data, albeit from one site, it does have the strongest data and the sort of most enthusiasm by most people. But I would say that in an acute setting, it may be a little more complex, and so either a tap or a culotte may be quicker in a case like this. But nicely done. Well done. Thank you.
Okay, thank you very much. We'll move on to our last presentation. And okay, wonderful, you're here. Okay, I can't pronounce your last name. Jenny?
Yeah.
Namkoong. Namkoong, all right. And you'll be speaking on the catch of left main stenting. Thank you.
All right, good afternoon, everyone, and thanks for the introduction. My name is Jenny Namkoong. I'm a first-year interventional fellow in Winnipeg, Canada, just started, but originally from Australia. So I'll be presenting to you a case that I've titled The Catch of the Left Main Stent. So if you follow along with me now, we have an 82-year-old male with a known history of coronary artery disease with previous PCI to the ostial left main back in 2015. He also has a background of muscular dystrophy and chronic atrial fibrillation for which he is on apixaban. This time, he presents with worsening angina and exertional shortness of breath, and an echo shows worsening ejection fraction decreased to 40%. And thus he was referred for coronary angiography. I'm going to first show you his angiogram from 2015. In the diagnostic images, which is post-nitroglycerin, we can see the ostial proximal left main disease, for which he received a stent. He did have circumflex disease at the time, but it was left alone. And on the right here, I've included a stent-enhanced shot of the well-expanded left main drug-eluting stent. And now to the angiograms from this presentation. A femoral approach was opted as the radial pulse in both arms was not able to be appreciated. The diagnostic images showed that the left main stent was patent. It was a left-dominant circulation, as you can see, with worsened calcific circumflex lesion compared to the 2015 angiogram, evident in the arrow caudal shot on the left. And the LAD had mild to moderate atherosclerosis, but no flow-limiting lesions, as shown on the right. Here are more of the diagnostic pictures. And the RCA was a small non-dominant vessel. The LVEDP was 11. And so we decided to proceed with PCI of the circumflex artery. An XP 3.5 guide was initially used, but despite multiple attempts, the wire could not be directed through the center of the ostial left main stent. Both these images show us struggling with the XP 3.5. So we exchanged to our XP4 guide, and with this we could position the guide in the center of the ostial left main and wire into the circumflex. A semi-compliant, then non-compliant balloon was easily delivered to predilate the circumflex lesion. Unfortunately, however, delivering stents proved to be quite challenging. There was a spot in the mid-circumflex where the stent just would not cross despite multiple attempts. So we tried to use a guide liner, but could not cross the left main stent with this either. And after further aggressive preparation of the lesion, we tried again to deliver a stent. However, this time, it got caught on the distal circumflex, and then when trying to retrieve it, it got snagged onto the left main stent. This is the circumflex stent that's stuck on the old left main stent, and the guide catheter withdrawn into the aorta. With some not so gentle pullback, we were able to dislodge the circumflex stent and pull it back into the guide and remove it from the patient successfully. But did anybody notice what happened prior?
It's accordioned.
Yes, correct. Unfortunately, the earlier guideliner use led to accordioning of the left main stent, which probably left it more susceptible to catching the left circumflex stent as it was taken up and down. So we went back to engage the left main, and this time we noticed this. We found that the left main stent had also been removed. It turns out that when the new circumflex stent that wasn't yet deployed, that was caught in the old left main stent was pulled out, it pulled out the old left main stent with it. As on the table, on closer examination, we could see both stents concentrically on top of one another. Thankfully, the left main coronary artery itself filled properly with no dye staining or dissection. As such, we proceeded with PCI of the left circumflex. Without the left main stent causing stent interaction, we were able to deliver the guide extension distally and then stent the lesion distal to proximal with two 3.5 by 20 Promus Premier drug-eluting stents. The whole segment was then post-dilated with a 3.75 NC balloon. Unfortunately, there was still a spot that was not fully expanded at the bend of the circumflex, as you can see in these images, despite NC ballooning for a full minute. This was likely due to a calcific nodule, and we didn't have OPN balloons available at the time. There was a proximal edge dissection also that we had to further cover. And that brings me to the end of the case of the catch of the left main stent, whereby the old left main stent made delivery of the new stents into the circumflex difficult, and the 7-year-old left main stent that was further accordioned caught the new circumflex stent, but in the attempt to dislodge the circumflex stent from it, the old left main stent also dislodged. And with that, I would like to open the floor to comments and questions.
Very nice case, thank you. So you've had trouble engaging it with the diagnostic catheters, the Vodal F35 and even the 4. Would you think that your initial wiring could have gone through the struts, the side struts?
Yes, I think that's quite possible. That made it quite difficult in the, I think that with the last guy that was used with the XB4, they did it quite a few times and tried to loop it in so that to make sure that they went into the actual lumen of the left main stent. So the operators were quite confident that the final wiring was through the lumen itself.
And in hindsight, do you think that the accordion happened during the guide engagement or the attempt to put the guide liner in?
I think that it's most likely that it was in the attempt to put the guide liner in, but it's possible that it could have been from multiple things, yeah.
I have two interrelated questions. Did you image this?
Yeah, that's the question I was expecting, and I'm surprised it wasn't the first question. So I think that we would have really loved to image. In real life situations, this case took a lot longer than we expected, so there was somebody waiting, like a STEMI waiting. And in hindsight, after the next case, we were like, we should have imaged that case. So ideally, we would have imaged not only the left main to make sure that there wasn't any mechanical problems from the left main stent being dislodged, but also the peripheral left circumflex prior to stenting when it was difficult to stent initially, I think would have been ideal.
And I'm thinking as much about pre-procedure imaging, because just conceptually, you've got a 6 or however year old stent here that should be really well epithelialized. And if it's not hanging out in the aorta, you shouldn't be able to wire through the struts. That suggests that maybe you had some stent extension into the aorta or something from before. And that's sometimes where our eyes are great, but not as great as some of our imaging tools, and they can help us troubleshoot these things.
Yeah, I would agree.
I just have a question for you. What do you think in hindsight? How would you have prevented this? And that's for the panel as well. How do you think? Is it more preparation? Is it using guide liner up front? How would you
have done this if I had to do it again? I think earlier sessions from the coronary session, like the calcification session, etc., made me think a lot. I think that if you know that there's a left main stent and you're not sure exactly where it starts and finishes, especially if it's done somewhere else, to image that first to see if you're going to have any trouble engaging, not just with the catheter, but also like guideliners, etc. Seeing that it's a calcific lesion, to IVUS down the left circumflex as well to see if you can prepare the lesion better. If you need to, in retrospect, we could have used other, we could have used, atherectomy, we could have used lots of other ways to get to the calcified lesion and not had the trouble that happened, which was the stent that got stuck in multiple occasions. Yeah.
Yeah, I think those three are really important. Imaging, first thing, I probably would have wired both LAD and the SIRG just to stabilize the guide, and then gotten the imaging first, and then vessel prep. With calcium, it's really, it looked calcified, so vessel prep was really, really important, and opening the side struts and getting some imaging would have really helped, and if you could do that prep, that would have really prevented it, I guess.
First of all, congratulations on the great result, and you handled it very tactfully. I just want to make a comment that, the classic teaching had been in the past that, if you are through a stent strut, an IVUS catheter or a balloon is not going to cross. And so you can be pretty reassured that, you are through the center of the stent struts. Being learned the hard way, but that's not true, especially because with the newer generation drug-eluting stents, they're ultra-thin drug-eluting stents now. So you can easily get your IVUS through the stent struts, or even a 4-row balloon through the stent strut, especially if the stent is well expanded. And in these situations, of course, imaging helps. What I've found most useful are the stent boost and clear stent images. And I normally, if I have concern about going out of the stent strut, then I usually take those stent boost images in multiple views so as to make sure, and of course, image as well.
Yeah, thank you.
So just out of interest, do you know what type of left main stent this was?
I'm not entirely sure, but I do think that would have, they have, a little bit of data about which stents are more likely to dislodge, but I'm not sure exactly which ones.
And do you know at the time of the initial, and I don't know if you mentioned this, but at the time of the initial stent implantation, did they use imaging at that time?
They did, correct.
And
they were happy.
They were happy with it, okay. The only other thing I would say is that, obviously this is all kind of in hindsight, which is always 20/20, but if there's any kind of more proximal stent that you've got to go through, putting a guideliner through it to avoid any interaction between the new stent that you're trying to put through is obviously, usually the best strategy. I've had several cases where we've lost stents just like this, and then managed to retrieve them because of this. And so putting a guideliner in, if you had a guideliner in through the left main into, say, the proximal circumflex in this case, I think it would have gone, very smoothly. You would have eliminated the interaction between the subsequent equipment going in and the ostial left main stent. The safest way of probably doing that is to advance the guideliner in over a balloon. And so there's a sort of, you can either do a balloon anchoring technique of getting the guideliner in, so you inflate the balloon into the circumflex and use that to guide your guideliner in, or you can even use it to inflate at the tip of the guideliner and sort of use it as a balloon tracking to sort of just get past the stent and then down into the circumflex. So that may have been another technique to kind of avoid this. Yeah. I have also seen one case where the left main stent had become so mangled that the operator actually, with a biotome, snagged the ostial left main stent and took it out just to sort of avoid this and get it out of the way and re-stent everything. But great, and I think that the other thing that sort of probably helped you through this case was maintaining your wire through this, because imagine if you have an accordion stent or some loss of stent, and now your wire has somehow become pulled back. That's a whole different algorithm and a different discussion, but at least that wasn't the case here. But a great save and a nice final result.
I had a quick question for the panel that just came to mind. We didn't get to image the left main after the stent was pulled out, but say that there was nothing that you could see mechanically wrong with the left main, would you have re-stented it or left it alone?
That's a really good question. What does the panel think? Salman, what do you think? So if you had imaged the vessel and there wasn't anything obviously wrong with the left main, would you have re-stented it?
Well, I think it depends on which imaging. If it's OCT and shows everything is good, maybe not. But if it's IVUS, there's always something that we're not seeing. then I would.
It is quite a little bit worrisome. You said it was 5, 6 years old, right? I can't imagine the stent coming out without pulling out the epithelial, like the lining of the vessel. So that worries me a little bit, of course, and I think I would lean more towards putting in a stent.
Yeah, I would definitely IVUS, and I think it would be hard to OCT the left main there, but IVUS it and then probably put a new stent in.
Yeah.
I would be tempted to re-stent to just as a framework for re-epithelialization, because you have to expect that it's been significantly disrupted at this point. That would be amazing.
Yeah. I guess this is a poor man's absorb, I guess, in some ways, right? It's done its job, and now you're taking the stent out.
Yeah, and I'm not sure if you need to consider like the circumflex stent, you might need to go back later, and if you re-stent the left main, if you'll have trouble, but that's something for another day. Yeah.
It does also raise the question, I'd be curious to actually see the original imaging and whether or, because, I mean, as we've all said, I mean, we would have expected, if this was properly expanded and opposed, we would have expected, adequate epithelialization at this point. And so.
It's interesting. Are you able to go back to that still frame of your original left main stent? Because the little comment I wrote to myself in my book is that it does not look completely expanded distally as compared to the ostium. And it's hard to know if that's because you're flared out in the aorta or what exactly occurred. To me, that looks like it's less well expanded distally than it does proximally, I think, without the corresponding.
Unless, of course, they purposely flared the ostium and and the vessel tapered for some reason. But no, it's a good point.
I think your initial angiogram actually shows almost an expansion from a really focal osteal lesion. So there should have been a fairly roomy mid-left main to work in.
Yeah.
Great. Well, thanks so much. Congratulations for a great case. Thank you.
Thank you.
Okay, we have, that was our last speaker, but before we kind of adjourn, just to sort of, for the panel to put our thoughts together on the winners of this session, I want to just give one last chance for anyone who wasn't here earlier. So because we have 2 or 3 speakers who were slated to present, but who were not here. So final call for Dr. Mohammed Orabi? No? Dr. K.S. Radide? No? And Punish Sadana? Okay, great. So give us a few minutes. We're going to discuss the cases amongst ourselves, and we'll be back with you in a few minutes with the final results. Okay, guys, thanks for your patience. We have tallied up the votes. So the way we did this is each panelist voted for their top 2 cases, and we gave 2 points for a first place vote and 1 point for a second place vote, tallied up the votes. And in second place, we have Dr. Ankit Patel for his SVG case. But in first place, for her catch of the left main stenting, we have Jenny Namkoong from Canada. Great. Thanks so much. Congratulations to all the participants, and thanks all for joining. We'll give you back about 10 minutes, 5 minutes of your time. Thank you.